Dr. Grenda earned his bachelor's degree from the University of Michigan and his medical degree from Lake Erie College of Osteopathic Medicine. Completed an anesthesiology residency at Temple in Philadelphia, followed by a fellowship in advanced airway management and head and neck anesthesiology at the University of Michigan. He currently serves as the director of anesthesiology for otorhinolaryngology and oral maxillofacial surgery and is an assistant professor of clinical anesthesiology at Jefferson. Dr. Grenda's research focuses on novel, non-invasive oxygenation techniques and standardizing difficult airway management. He is also actively involved in initiatives to improve interdepartmental communication and enhance patient safety. He'll be speaking on topics in airway management, including the use of high flow for airway management. Dr. Grenda?
So again, my background is in head and neck anesthesia. That's kind of what my interest is. And I've been privileged over the past several years to be lecturing on the use of Thrive. And those that are not familiar with Thrive, it's essentially the application, the anesthetic application of heated high flow in an operating room or anesthetic setting. And Thrive stands for Transnasal Humidified Rapid Insufflation Ventilatory Exchange. So you could imagine that we needed to come up with a more simplistic term. So Thrive. Over the past several years, I've given this a similar talk to departments of anesthesia, and then over the past year or so, a lot of the Department of Otolaryngology have kind of latched onto this, and it's been very fulfilling. So we'll go through a couple different things, including the basic components and setup of Thrive. We're going to look at the different mechanisms and physiologic effects at play. We'll describe some of the potential uses, contraindications, potential risks. Probably more interesting is the applications in practice and some of the future directions that we need to take a look at. And those that have heard this talk, just briefly, does anyone recall, or in their practice recall what high flow was originally designed for? Any specific patient population? Any thoughts? Boom, peds. So actually in the early 2000s, it's been utilized in the pediatric population. And why it did not roll out to an adult population until probably around 2014, 2015, I have no idea. But since that time, it's been utilized in ICUs, perioperative arena, as well as some people are even using it at home. I don't know necessarily how that works, but nonetheless, it's been pretty well documented over the past several years. And I remember as a resident reading an article in the Anesthesia Patient Safety Foundation that kind of outlined the use of high flow beyond the ICU, and they really coined that term Thrive, so Transnasal Humidified Rapid Insufflation Ventilatory Exchange. It is a mouthful, no doubt. Nonetheless, it outlined much of the components of Thrive and discussed some of the potential uses. So it is a high pressure system that flows into a blender. And most of the flow meters have the capability of delivering up to 100 liters per minute. And then there's the humidifier. So that's really, I think, some of the benefit comes in because patients tolerate this quite well as opposed to just getting blown with dry air. There is a wide bore tubing. And then there's the heated circuit that provides more of the humidification and specialized nasal cannula. And this is the example of what we have at our current institution. And by no means is this a sales pitch. This is just the OptiFlow, and that's the one that I was trained with during my fellowship. And as you can see, there's a flow meter, there's the humidifier, there's the wide bore tubing, and then the nasal cannula. Relatively simple. And that's just an example of what the actual cannula looks like. And the standard setup encompasses, you place the cannula on the patient, a spontaneously ventilating patient, range flow rate between 20 and 40 liters per minute. I do agree that 30 liters per minute is usually the sweet spot. Some people exceed that, but the goal is to reduce entrained air. And if you're using it for a primary airway modality, as you go to a more apneic state, you want to increase your flow rate typically to about 70 liters per minute, and in order to exceed the patient's inspiratory flow rate, so there's less entrained room air. So what are some of the physiologic factors at play, and how does this actually work? How is this an effective modality for airway exchange and oxygenation? And the concept of apneic oxygenation has actually been around for some time, including an article that was written, I had to go digging for this, in 1891, published in the Journal of Physiology. They coined this concept of respiration without respiratory movement, and they hypothesized that through cardiogenic oscillations and the creation of turbulent flow, you could effectively oxygenate a patient. Now, one of the main physiologic parameters that's mitigated with the use of high flow is physiologic dead space, which we think back to medical school and even studied for the basic. That's made up of typically anatomic, so non-respiratory airways, and your alveolar dead space, which in a normal patient equates to about 2 mLs per kg. And use of high flow actually reduces anatomic dead space. And it does this through more efficient ventilation, through the creation of those, again, highly turbulent flow vortices, and aids in CO2 clearance. It provides some degree, and I know a lot of people have questions about this, provides some degree of CPAP. Based on the literature cited, on average, somewhere between 3 and 5 centimeters of water in different patients, and there's been some discussion about patients that you shouldn't necessarily use Thrive for. It could provide upwards of 7 centimeters of water of CPAP. It does assist in the process of oxygen diffusion in the alveoli, and I think more importantly, particularly in some of our sicker patients, it assists in the process of oxygen or improve thoracoabdominal synchrony and reduces the respiratory rate, which in doing so decreases the work of breathing. It provides humidification, as I had mentioned, which enhances mucus clearance and improves ciliary function, which in turn reduces atelectasis. And the typical humidification heated system heats to about 37 degrees Celsius. It reduces airway resistance. If you think about Poiseuille's law and rearranging for flow rate and resistance, you can actually see how by increasing your flow rate, you're reducing the airway resistance. Now, taking this into account, you can see maybe in your day-to-day how this could be beneficial, right? So you could use it for, pre-oxygenation for induction of general anesthesia. You could use it for an awake tracheal intubation, oxygenation during a procedure in and of itself, either under general anesthesia with the use of paralytic as well as with MAC cases, which we're currently using at our, I learned this past week, at our current institution. And there's discussion about using it for post-extubation. I was actually just talking with one of the ICU attendings earlier today about their interest in examining this a little bit further. Of course, I mean, it's always fun to play with new toys, but there's always some relative or absolute contraindications to keep in mind. So partial nasal obstruction, most of this is relatively intuitive. A disrupted airway, of course, inability to tolerate hypercarbia because, and I'll cite a study a little bit later, it does provide airway exchange, but there is potential for an increase in CO2, which also requires further study and monitoring. Contraindications to high oxygen concentrations, such as use of laser, need for laser, and infections. And then absolute contraindications, complete nasal obstruction because there will be no flow. Active epistaxis, I understand that. There's a little bit more discussion about its use following FES. So I've been a part of a couple panel discussions with the otolaryngologists at their national conference and looking at patients' status post-FES and the use of CPAP or low pressure, positive pressure systems. And the consensus at this point now, granted it needs to be studied, is that it's actually safe. It's actually safe to use, and the ENTs typically are not going to object to it. Skull-base fractures and CSF leaks, of course, probably not the best idea to be utilizing something that's blowing air into the nasal passage. And then significant pneumothorax without a chest tube, probably not the best idea. All right, so now we got that out of the way. Let's look at some of how this is being studied today, how it's being utilized in clinical practice. So I think back to when I was initially researching Thrive as a fellow, and there was a groundbreaking study in 2015 published in Anesthesia, and it was the first time that I had seen Thrive being utilized in the adult population. And it was a small study cohort of 25 patients, and they looked at data for procedures that were coming for hypopharyngeal laryngeal tracheal procedures. And essentially, they got the patient in the operating room, they hooked them up to their Thrive system, They increased the flow rate to 70, so that was their chosen flow rate for pre-oxygenation. They induced anesthesia. They confirmed maskability after rocuronium was set in, and they just watched. And they just waited, and they watched and waited, and eventually they got sick of waiting, or they exhausted their protocol time or cutoff, and they found that the median apnea time was 17 minutes. 17 minutes. Not a single patient in the study desaturated less than 90%. So you can imagine, I can think of a few in the back of my mind here, that I certainly could have used this for recently in order to extend that kind of apnea time. And they hypothesized this was due to flow-dependent dead space flushing, as I previously discussed. And since that time, we've seen it kind of built into some of our national guidelines and protocols. For example, the consensus statement proposed by the Difficult Airway Society, and I've talked to a few of you about this in the past. So there's three main societies with regards to head and neck anesthesia that provide recommendations, or their proposed recommendations to the ASA and some of the other international groups. There's the Difficult Airway Society. There's another group, they're like, we need to incorporate some more specialties, so Society Airway Management, and then, of course, the Society of Head and Neck Anesthesia, which is more US-based. But nonetheless, they proposed their set of guidelines based on survey from 43 international experts and a 10-member guideline team. After a 3-round Delphi, they proposed their recommendations for 4 different areas. So oxygenation, topicalization, how the awake fiber optic should be performed, as well as sedation that should be provided. And at the time, based on the current literature, desaturation rates for desaturation less than 90% for low flow compared to high flow. Low flow incidence approximately 12 to 16%, as opposed to high flow somewhere between 0 and 1.5%, so pretty significant. And based on their set of their consensus, they recommended that oxygenation, you should always be using high flow in these types of situations. Again, the range is somewhere between 30 and 70 liters. I feel, in my experience, anecdotally, that usually 30 is the right flow rate for a spontaneously awake patient, spontaneously ventilating, and that you should continue the high flow throughout the intubation. And piggybacking on this, they mentioned topicalization. And I was actually just discussing this with our chair the other day. It works incredibly well. And I think it's mostly related to, again, those high flow vortices create a downward force on the vocal cords. And you'll find that even your amount of 4%, typically we use 4% for airway topicalization, will go down. This was just a correspondence that was written actually by several of my mentors from fellowship, just documenting their approach to awake tracheal intubation and how to topicalize the area, or the oral pharynx. And again, the use of high flow, 30 to 40 liters per minute is the recommended. And this was actually my program director drew the short straw to get his photo taken. But this is outlining kind of the basic setup. So you can see the Thrive system off to his left. You can see the fiber optic cart, very fancy. Nebulized lidocaine, we kind of phased that out during the pandemic, and I never really came back to it. So I kind of just used the atomizer with the Thrive on, and usually, again, it's pretty effective at topicalizing the airway. We've also seen it kind of spill over into management of the physiologic difficult airway, and I know a lot of the ICU attendings are very interested in this, and I think probably not till around the COVID pandemic really brought this to light. And even recently there was an article in anesthesiology looking at this concept of the physiologic difficult airway. And anyone that's been involved in airway management or somebody that's in acute hypoxic respiratory failure, particularly during the COVID pandemic, knows what I'm talking about. The hemodynamic swings and sudden drop in SpO2 is very profound. But nonetheless, Society of Airway Management came up with a set of guidelines based on 12 airway specialists, and after their Delphi method, they identified 2 areas to address the physiologic difficult airway, so hypotension and hypoxemia. And based on their consensus, they found that They recommended that pre-oxygenation should be performed using high flow for at least 3 minutes prior to the induction of anesthesia or 8 vital capacity breaths. And it was a 99% agreement. Now, switching gears to the probably more interesting and more common things like anatomic difficult airway. And I'm always in the practice of trying to identify the patients that are going to be either difficult mask ventilation or difficult direct laryngoscopy. And this was a pretty also groundbreaking article that came out in 2013, also out of the University of Michigan by Sachin Ketterpal. And they looked at data for over 176,000 patients over the course of 6 years that had information on maskability and direct laryngoscopy. And they defined difficult mask ventilation as a grade 3 or 4, so two-hand or not able to mask ventilate at all, as well as direct laryngoscopy, so grade 3 or 4, so epiglottis or no view at all, or greater than 4 attempts. And the incidence of this reported somewhere along the lines of less than 0.5%, which seems kind of minor when you think about it. But if you could do a better job of identifying different predictors to even reduce this number even further, obviously that's certainly ideal. And what they identified were certain risk factors such as Malampati, prior neck radiation, the thyromental distance, thick neck. All these things are kind of incorporated into our day-to-day workflow. And I think based on articles and studies like this, it's kind of laid a lot of the foundation for what we see in our difficult airway algorithm and recommendations today. There was actually a great review article published in 2019 based on looking at data in the literature that described difficult mask ventilation and difficult direct laryngoscopy, and it focused on prevention and planning. And based on the current data at the time, they proposed that pre-oxygenation should be applied to all patients prior to induction. Of course, we do that anyway. But pre-oxygenation in THRIVE has been shown to delay the onset of hypoxemia, and up to 70 liters per minute has been shown to reduce CO2 and provide tolerance to apnea for prolonged periods. And since that time, we're fortunate that in 2022, the ASA actually adopted a similar methodology, and it's been incorporated into the guidelines for management of difficult airway management. And then switching gears again, my specialty is kind of the head and neck realm of things. So looking at it actually used as a primary airway modality, it's been used quite successfully for micro-DL procedures, laryngeal stenosis procedures, and intermittent apnea. And it's been studied on the surgical side as well, and we'll get into that in a moment. But just a basic setup for a procedure like this, you have the patient, again, THRIVE, 30, 40 liters per minute. You have them spontaneously breathing. You always do a timeout before any of these types of procedures just to make sure that you have the appropriate emergency airway equipment and everyone's on the same page about what the plan is. You have the attending otolaryngologist in the room, and then you induce the patient. As soon as the patient goes apneic, you start to increase that flow rate to 70 liters per minute. You provide a jaw thrust, and or if it's a head and neck procedure, typically just hand it off to the ENTs because any direct laryngoscopy will relieve any obstruction that may be taking place. Maintenance of anesthesia for these are TIVA, so propofol, Remi, or your opioid of choice, but I've had great success with remifentanil, given that you're probably doing this for a 30, 45-minute procedure or less. And then I always get the question about CO2 monitoring, which is kind of challenging, right? Because you're flushing the airway at a very high rate. So some people and some studies have even cited the use of transcutaneous CO2, which most institutions I don't think have. But the alternative is, and then probably a little bit overkill, is that you're going to have to get ABGs if you really want to see what the CO2 actually is. On the surgical side, again, they've been very interested in this over the past couple of years. Even this study that was published in Laryngoscopy back in 2022, they looked at data for 35 patients over a 3-year period that were covered for DL endoscopic debridement of subglottic stenosis. So subglottic stenosis is a pretty tough airway pathology. Oftentimes goes undiagnosed. But anything you can do to prolong the apneic time in these types of situations, I'll certainly take. But they compared low flow via 10 French catheter, which was positioned by the otolaryngologist, versus THRIVE. And what they found was kind of interesting. So median apnea time for the low flow was actually longer. It was 34 minutes. versus Thrive, which is 25 minutes. What I suspect happened is that being that it's positioned by the otolaryngologist just above the vocal cords during the procedure and throughout, probably offered some degree of advantage. However, the low flow had multiple complications and required rescue maneuvers at least 3.5 times more compared to the Thrive. The biggest contributor to failure for both intervention was BMI greater than 35. So I think that's certainly keep in mind. Similarly, in the British Journal of Anesthesia back in 2022 as well, big study, 118 patients. They looked at high-flow nasal cannula versus tracheal intubation, and their endpoint was the lowest SpO2 within 30 minutes. So they actually induced anesthesia, transitioned, started their procedure, and recorded SpO2. And as you can see at the very top in A, the light blue is your Thrive, your high flow, and your purple is your tracheal intubation. And not dissimilar, even after 30 minutes. It is important to note, though, I think, the transcutaneous carbon dioxide measurements, obviously it's going to be not as great as endotracheal tube intubation. Based on that study, the editors hypothesized and promoted the fact that high-flow nasal oxygen may be as effective as tracheal intubation and oxygenation during laryngeal microsurgery. However, you do need to keep in mind that you always have to have a backup plan. Smaller endotracheal tubes, LMA nearby, just as in the event of a rescue maneuver. Last but not least, extubation and its use. And I think this is an area that needs to be better studied, both from ICU attending perspective as well as with respiratory therapists. I know that's been a little bit of a barrier because, I mean, it takes work. Most units are pretty busy, and it's just another piece of equipment that someone has to set up. But I think the literature kind of speaks for itself. But this article, they identified 527 patients over multiple institutions over 2 years. And they looked at, unfortunately, low-risk patients, so less than 65, BMI less than 30. No significant past medical history like severe COPD, heart failure, and obviously they had a patent airway. And they found that the use of Thrive immediately following extubation reduced the risk of reintubation within 72 hours. Just in my personal experience, I think Thrive and its use, as I described, has a high level of success for topicalization. Increased patient satisfaction and tolerance. Patients tolerate this quite well. I know it seems a little bit aggressive even at 50 liters per minute, but the fact that it's humidified, the fact that it's heated, patients tolerate it quite well. And you can imagine somebody that's coming in through the ED that's huffing and puffing in acute hypoxic respiratory failure, just having a little extra support goes a long way. The benefit to patients with partially obstructed airway, it again reduces the risk of, reduces the work of breathing and airway resistance. And then the small amount of CPAP again is certainly helpful in even partially obstructed airways. I think there is room for future investigation with regards to the use of Thrive and which patients we should be utilizing this on. I think, again, as I mentioned, extubation outcomes. I think there's certainly room for further investigation into that. And then I always talk about the failure to Thrive. So which patients or parameters are gonna set our patients up for success, and which ones should we just be completely avoiding this with. And then again, the discussion around clearance of carbon dioxide in comparison to other techniques such as jet ventilation, which is a high pressure system. But I think the fact that even discussing this with many of you, I'm excited that other people are excited about this. And I think now that we have it, I just learned this past week, we have it at our institution, we're going to see more and more people taking hold of this and utilizing in their day-to-day practice. And that's all I have for you guys. Unfortunately, I have to catch a flight to get home to my wife and my 1-month-old. So I'm going to take any questions at this moment. Thanks for paying attention and being here this afternoon.
Thanks, Dr. Grenda.
I just had a quick question. When I do a fiber optic, if I can, I try to do a transtracheal nerve block where I put a 20 gauge through the cricothyroid membrane. Do I have to worry about that hole if I'm using Thrive?
Great question. In my experience, no. Typically, you're using a small enough needle that it should not interfere or cause increased risk of fistula tract. Good question.
We've been using this in the ICU for a while. Let's go to the next question. I have a question about cost. Have you had discussions on cost? Obviously, efficacy is the most important thing, but was this a challenging acquisition for you all in the OR?
So it's interesting because I actually requested this probably about two and a half years ago to have it at our institution, and we finally just got it. But my understanding is that the tubing and everything comes as a kit. It's about $200 a pop for, I think it's like 10 or plus circuits that come in a box. But again, it's relatively cost effective compared to some of the alternatives.
Dan Neubauer from Wake Forest. Couple questions, because we've used this a little bit in our GI unit for a little while now, but have you had, is there a specific patient population you've chosen to try and do your laryngologic procedures with versus just doing regular jet?
Yeah, so, that's a great question. I think still trying to get our department on board, but at least with in my prior institution and during my time in fellowship, typically the shorter procedures, 30, 45-minute ENT procedures, so DL biopsy, DL tongue biopsy, I typically did not do it for subglottic stenosis patients as the primary airway management, but to bridge the gap. So say, for example, someone has significant glottic stenosis, that their arytenoids are almost fixed. Pretty much all those patients, we use Thrive, at least as the initial modality to get them off to sleep, just to give us a little bit of a buffer until we establish a secure airway.
I think the next question was,
was in regards to like different demographics and things like that?
No, lost my train.
Okay.
Who sets this up for you in the operating room? Do you guys, or does the tech have to do this? Or?
Historically, it's always I just do it.
Yeah.
But I think now that we have it on multiple floors in our hospital, the techs are going to start getting equipped to deal with it, because it really is a pretty easy setup, as long as you have a little bit of some time.
We task our respiratory therapists in the ICU, so it's a bit of a black box for us
Right.
to set up.
Right.
They just bring it and it's ready.
And I think that's one of the barriers, just speaking with some of the ICU attendings here. Yeah.
Any other questions for Dr. Grenda?
What is the effect on gastric pressures? Like how much air is getting entrained into the stomach
In
when
theory,
using this?
because it is a low pressure system, it shouldn't cause significant gastric distension. Again, it's always a concern, right? But assuming that a patient is following, NPO guidelines, and there's no contraindication like GLP-1 or something like that, there hasn't been an increased incidence of, significant GERD or reflux or anything like that.
All right, great. Please join me in thanking him for